receiving ABA services to the age of 26 as opposed to 21. And I just wanted to see, make sure that would be agreeable with you. And but that would be a recommendation we would like to make, to extend ABA services to make it fit all the other ages, at 26 when healthcare is extended.
Kim, I see your hand up. Thank you, Representative Exum. We have Kim Meerman on the line.
And
Okay.
thank you for raising this concern. I'm Kim Meerman. I sit on the council as a parent, and
Okay.
we actually do have this in our legislative priority, and I am a
Great.
parent of a 22-year-old, and I have been having ongoing battles with my insurance company over this very issue. And I would respectfully like to request that we remove the age limit entirely. It is the only service that does have a cap. And,
Yes.
she depends on BCBA services to continue to make progress and to be able to be fully independent. And with that
Yes.
service, we have seen continued growth. And I foresee the possibility of her being able to live independently and to be able to work competitively. And without that support, I would be reliant on her being forever on Social Security and Medicaid, as opposed to I'm seeing the opportunity now for her to be in a very different realm and potentially being competitively employed and having her own private medical insurance. So this is a very important topic for me.
Thank you so much for sharing that, and I really understand it. I am also the parent of a young man with, not young man, a young adult with autism, so I understand this very well. What we're doing is iterative, and meaning that this is a huge step from going to from where we are today to at least looking at that parity at the age of 26. I know it is the only service that's capped, so that's something we can continue to advocate for and address and see if we can find a way to expand. But this is something within our purview that we're able to try to do this legislative session. As you said, it's in the recommendations from this group. It's in the recommendations from my group. And also, we have a member who is from OPM, the Office of Policy and Management, who has vetted this as well, and he's one of the tri-chairs. So I feel really positive about this movement, and then we can continue to work, because I totally understand what you mean about wishing for this cap to not be there at all. But I think that will take more time, but this is something we can do in the short term. I really hope my legislative colleagues will agree.
Thank you so much for your support on.
You're welcome. You're welcome. Are there any other? Yes, go ahead. I'm sorry.
No, hi, Representative Exum. It's Gemna. Thank you so much for calling in.
Hi,
and I know you're double booked this morning. So we do have remaining members of the council on the line and
Okay.
that have just joined. So I'm just going to pause 1 minute. I know you're pressed for time as well, but I didn't know if there was any other comments related to Representative Exum's update about the iterative proposal to put forth.
This is Lois Rosenwald. I'm sorry I missed the first part of this, and I just got on. I guess I had the wrong Zoom information. So I'm sorry that I missed the first part of this meeting, apparently.
Good morning, Lois. I'll repeat for members who've just come on. I was just expressing I have to leave shortly. I have a meeting at 10:30, a caucus that I have to get to. But very important, and I think is a wonderful recommendation. I'm a tri-chair of a committee called Transforming Children's Behavioral Health Policy and Planning Committee. And one of the things that we would like to recommend is an increase in the age for ABA services from the age of 21 to 26. And that would be one of our recommendations. And I just wanted to bring it before the body today just to see, for feedback, to see if this was in alignment with what you would like to see. I know this is important for our community, but I wanted to make sure that I vetted it with this group and just got feedback as well. So we were just talking about that. And so just wondering if there were any other comments. Yes.
Thank you.
And I do have.
Sorry,
Go ahead,
I'll just say real quick. I know that you need to, go at 10:30, but I'm also planning to send out the recording as we review our legislative priorities and the PowerPoint slide that we are using for today. So I will ensure that you get a copy of that. I will also be available during TCB today. So if, and I work under Claudio. So if there's any additional information that comes out of today's meeting, I will be available to help fill any of those gaps.
That would be wonderful. Thank you so much for that. Thank you. And that's great alignment.
Yes, I do have one hand raised. Representative Exum, if you could still hold the line. Go ahead, sir.
Okay, sure.
Matt, is that you?
Oh, yes. Hi, this is Senator Lesser. I actually was just going to see if I could follow up on Representative Exum's request and ask my own request of the group, which is I serve as the Senate co-chair of the Human Services Committee, and my co-chair, Representative Gilchrist, and I have been looking at a request to seek data on the total number of individuals in DDS care who have autism diagnoses. It's my understanding that we don't have that information on hand, and some folks have expressed that might be a very useful metric. And I just wanted to see, take the folks' temperature and see if that was something that you thought would be a good priority.
I think we're going to address that, Representative or Senator Lester. Are you able to stay on the remaining duration of this call, or do you also have to depart early? Because I know we do have a packed agenda and an update for you.
I will do my best. I'm between meetings, but I will do my very best.
Okay, and we are recording. So, Tara, unless you think otherwise, I think we should get kicked off, and we can bump up legislative priorities to the top of the agenda if Kim and Patrick are both ready to get us started.
Sure, we can do that, and we can do public comment after, just so that everyone can hear. And then again, just to repeat, I will make sure that all legislators who are participating or invited today will receive a copy of the materials.
Thank you so much.
Thank you.
Thank you.
Okay.
Right.
Are we going to
start
sharing
the PowerPoint for you? So just give me 1 second.
Great. Thank you. Okay, we're sharing now.
Good morning. So I've already introduced myself. I'm Kim Meerman. I'm on the council as a parent of and my daughter is 22 years old on the autism spectrum. A couple of us got together and designed this presentation for the purposes of discussing our legislative priorities. Tara, you can skip to the next slide. So I'm just going to give you a brief introduction and background around the council. And then another member of ours, Patrick Hike, is going to give a little more depth to our legislative priorities this morning. So the purpose of the council, as you may be aware, there has been some shifts to put it under the Office of Policy and Management. And our main goal is to provide advice and opinions and support to policies and programs that relate to the autism spectrum. And we are hoping to really enhance those services, to improve the coordination of services, and to address any gaps that may be within this autism spectrum of services. There is a link to the website around the council where you can find some additional information. Our membership structure is very purposeful. We represent a broad stakeholder group, including individuals with autism spectrum disorders, family members, providers, from a wide variety of perspectives. Tara? So we really wanted to bring your attention to some very key points. We, of course, want to address a lot of work that needs to be done, but we were very purposeful in hyper-focusing our legislative priorities this session. Next slide. And I'm just going to kick us off before I turn it to Patrick to talk about the fact that we really want to be involved. And even just what happened this morning is a really good example of how we would like our voices to be heard, how we can be supportive in providing information from our various perspectives. So please do not hesitate to call upon us, to invite us to the table for anything that is involving autism spectrum disorder. As you know, it's a wide continuum of perspectives and a wide continuum of needs. So we want to be involved, and one of the very first ways that we can help be involved is a recent report that has come out. And I'm going to turn to Patrick to explain that further.
Great. Thank you, Kim. Hi, everybody. Good morning. My name is Patrick Hike. I'm the director of River Street Schools and Programs. I've been advocating for children and adults with ASD and intellectual disabilities and other disabilities for over 30 years throughout my career. I've worked in a variety of settings and in a variety of capacities, including clinical positions, volunteer positions, and administrative positions. My work on the committee started in April, this past April, when I was appointed by Governor Ned Lamont as an advocate for persons with ASD. So as Kim had initially started today, she identified basically 3 legislative priorities, and she spoke already about having a voice. Our group really wants to be at the table, and I hope after today's presentation, you'll see why that would be important. I'm going to talk about the next 2 priorities, but I want to draw your attention to a recent study that was commissioned by OPM. The study was entitled "The Evaluation of Statutory Definitions and Regulations, Intellectual Disability and Related Programs." Now, the purpose of this study was really to review the statutory definitions and regulations for eligibility to services for individuals with intellectual disabilities and autism. And they really examined kind of 2 key areas. They examined first the potential for new definitions for intellectual disability, which really included assessing whether IQ should remain a criterion for defining intellectual disability. A second area of evaluation was reviewing the level of need assessment tool that's used for service planning. This really has implications for and would necessitate identifying related programs that might need updates based on new definitions. And as you can see, we've hyperlinked the report by the Alterum Institute. And by the way, the Alterum Institute is a nonprofit organization focused on improving healthcare systems for people of all ages. Basically, the goal of this study and why OPM commissioned the study in the first place was really to improve access to services and to strengthen home and community-based supports that are tailored to individuals' functional and adaptive needs. Tara. Now, the report is quite lengthy. It was released this past November. I believe many people on the call, maybe all the people on the call, received copies of the report. It is not my intent today to review all of the recommendations of the report. I'll just very briefly say that the report outlined potential recommendations to changing statutory definitions, eligibility, enrollment workflows, the level of need assessment, and many other recommendations. But for the purposes of today and our legislative priorities, it was important for us to point out what the report cautioned. And the report cautioned, and I took these quotes from the actual report themselves, that prior to any full adoption of any proposed changes, the changes could impact existing waiver program eligibility and the number of eligible program participants. And that Connecticut should begin with an understanding of and appropriate planning for any potential impacts. They talked about the recommendations and how they'll require strategic thinking and analysis and development before implementation. And so they really emphasized over and over again throughout the report the need for additional information and analysis. And it was quite timely this morning that Senator Matt Lesser talked about the need for more data. And that's exactly what we're talking about. And that's really our second legislative priority. Tara? Our second legislative priority is really evaluating needs, funding a needs assessment. Connecticut needs an extensive needs assessment.
Yeah.
We need to decide and examine whether or not needs are being met. Having this information will help us identify unmet needs, gaps in service delivery. This process will be transparent and the data will help inform next steps. The very good news, and we've talked about this a couple of times as part of our committee, is that we have a great model to follow. There's a great model called the Pennsylvania Autism Needs Assessment. This was a statewide needs assessment completed in 2010 and 2018. In 2010, it was the largest needs assessment in the nation. They had over 3,500 participants. Because the needs differ over time, because the rates of autism are growing at exponential rates, they redid their needs assessment in 2018. That survey was completed with over 8,000 participants and included two versions. They targeted individuals with autism spectrum disorder and their families and caregivers in 14 different languages. Other states have used their model. California, New Mexico, Texas, Oklahoma, Indiana, New York, Delaware, Puerto Rico has used this model to assess need across their communities. And so what we've estimated is that this type of needs assessment, if we were to model it closely to what's been previously done in Pennsylvania and other states, would cost approximately $150,000 and would take 15 to 27 months to complete. That's relatively a small amount of money to get data that is critical and necessary for us as a state to make decisions to best support our individuals and their families. It will allow us to be thoughtful. It will allow us to be strategic. It will allow us to be very mindful of how to take our next step. If we do it the right way, I'm confident with the right accurate data, with the best estimates, we're going to improve efficiency. We're going to improve effectiveness. We're going to reduce, we're going to increase cost savings across the board. Tara. Our third legislative priority is basically low-hanging fruit. It's low-hanging fruit. It's something that we can do right now. It's expanding access by making a few changes. We're advocating for removing the age limitations for access to insurance. Right now in Connecticut, the way that a statute is written, ABA services are only mandated through the age of 22. If we could expand services through medical insurance, that would allow us to take some of the burden off of Medicaid, and it would allow us to provide necessary and needed best practice services to individuals over the age of 21. Next slide. As many of you know, insurance coverage for autism-related services is required in all 50 states, but the coverage for the services vary by state, and the dollar and age limits vary by state. The federal laws that kind of precipitated autism insurance reform, the Affordable Care Act and the Mental Health Parity Act, once those were released, most states and most insurance policies were revised. In good faith, I believe, Connecticut disseminated bulletins back in 2014. And in those bulletins, they recommended that all carriers remove limits to applied behavioral analysis benefits. Unfortunately, that has not happened. That language in the definition of behavior therapy still exists. And insurance companies, instead of relying on these bulletins as guidance around the statute, they go back to the statute and they see the age limit, and that's continues to cap insurance coverage. That needs to change. Relatedly, behavior therapy and applied behavior analytic therapy, it's inequitable. It's the only service that might be available to individuals with autism that's capped. So there are no other caps on services that are provided to individuals with autism over the age of 21. Behavior therapy is the only one that's capped. That's inequitable. That needs to be changed. There was a law passed, the Special Education Law, Public Act 23-137, which in my line of business, because I work in a school, was, I thought, very helpful and thoughtful. It allows an extension of eligibility through IDEA that students can still stay in school the year they turn 22. However, that highlights this kind of service cliff, this kind of gap in service delivery, where they may lose benefits because they're 21 and not receive the services at home. So a bit of a gap of service delivery based on the age of the student and where they are. Lastly, we could reduce the number of people on the waiver wait list. People on the ASD waiver wait list who are not currently eligible for Medicaid, if we remove the age cap, if we extended it to 26 perhaps, that would allow access to services via insurance, thereby lessening the burden on Medicaid. Adults who receive a diagnosis later in life, after 18 years, with no access to the home community waiver, they would have access through insurance. And young adults who have access to services through the parents' insurance, if that age gap was removed or extended to 26 years of age, that would allow them to no longer have to access the Medicaid system. So I hope that these are some, good examples that could be used as a rationale for changing that statute that caps the age limit for behavioral services for individuals with autism. I think that opens up the door to quality services, to best practice services that could immediately be available. There are no restrictions really in the provision of those therapies. There's no additional licensing requirements involved. There's no additional burden involved. I think this, if I had to just say one last thing, I believe this is like a low-hanging fruit. This is something that with the right support, we could make this change and it would have profound effects. As we take the time to pursue our other legislative priority, which was completing this systematic needs assessment within Connecticut. Tara?
So really, at this point, I just want to clarify that the next steps from here is really getting support for these next legislative priorities. The main goals being funding the needs assessment and the changes to the age limit caps within medical insurance. Lastly, we really want to put forth the notion that we'd like a seat at the table. The most immediate seat that we want involvement in is around the impact of the study and the strategic planning for potential statutory changes around intellectual disability. This impacts us directly because part of developmental delay includes autism spectrum disorder. So that does directly impact us as a group. Sarah. At this point, we will open the floor up for any questions or discussion for what was presented this morning.
Great job. Thank you both, Patrick and Kim, for all your hard work putting that forth. Please use the raise hand feature and we can make sure we take your questions. This is being recorded. So if we need to refer back to it, we can. Hi, Marcia. I see your hand up.
Yeah, I'm sorry. I think that this is all great. One of my concerns is, as some of you know, I've been dealing with intense medical issues for a number of months now. That's why I haven't been around. But there are also services that aren't considered medical. As we've talked a lot about housing, and specifically housing that would have some support for, say, young working adults who could potentially leave home but need, support and some kind of, living arrangement. And we've talked about models of that, but we've talked about transportation. So I think housing is a critical issue as a sort of stepping stone toward independence and moving out of home. So I'm just wondering, could non-medical things also be covered?
Kara, was that included as part of the Pennsylvania study? Do you know in terms of like the caregiving aspect that was included in that second iteration?
The data, housing data is on was in the original Pennsylvania Autism Needs Assessment. So gathering, again, having that data to say, not just anecdotally, but, X amount of people who responded to the survey are showing that they need, I think that would really help inform future legislative priorities.
So to Dr. Eckert's point, it's not just level of severity of autism or where they are on the spectrum. It is truly a needs assessment and the level of the need, which would include, I imagine, some SDOH, housing, meals, transportation that would impact the what they're incurring and what's incurring on their daily lives, and how that impacts their ability to be a productive member of society, et cetera, and have the level of independence that they need. So if Connecticut were to model their needs assessment against, the Pennsylvania one, it sounds like we could capture that Marcia. Does that make sense? Or is in terms of just a start even? Is that kind of what you were getting at?
I think it makes a lot of sense.
Okay. All right. That's a great call out. Thank you.
Gemna, I'm sorry. I'm having difficulty raising my hand.
Oh, it's quite all right, Lois. Go ahead.
I think that there isn't any question that a needs assessment is the first thing that has to be done. It's long overdue. I think that until we really get that done, we're not going to have, it's going to be anecdotal. It's going to be people saying, this is what I'm hearing from folks. This is what, families are telling me when I talk to them. And I think that, we really need to clarify exactly what the needs are, and to be able to move forward and not have to, do a patchwork kind of thing. I think that, yeah, without belaboring it, to me, this is what needs to happen. It's actually long overdue.
Yeah, and I think as we heard from Senator Lesser, that was his initial ask is what's the opportunity that we have for gathering this data. Although I believe our this study that we're proposing and would need funding for is even more broad than what Senator Lesser was initially asking for. So I think that we, as he listens to this call and the recording and our slides, I think he'll see that this is even more broad than just the services that are, existing today, and what's that assessment look like. Hi, Stephen, go ahead. Oh, you're on mute, my friend.
I am always on mute. Okay.
That's okay.
I think that what the housing subcommittee that we have has been looking at a variety of these studies, many of which Patrick referred to from other states, and they have the numbers. One of the first things they have is the numbers, and we can look at those for a variety of purposes and what we'd like to do here, but we need the numbers. We need to know what is necessary here in the state. So I would second with Lois saying that is really the first step that we need in order to determine what we can and what we need to do here in the state of Connecticut. That's all.
Fantastic. Great. I love everyone chiming in. I don't see any other questions or comments. Patrick and Kim, thank you so much for putting together the presentation. We'll make sure that all of those slides are shared and distributed widely. I think that was presented really well and hopefully will give our legislators a lot to think about. Hi, Lynn. Good morning.
Good morning, everyone. Yeah, great job, guys. And I think one of the things that's, to me, is very encouraging about this is I think we want a voice, but I think it's important for us to collectively come together with a clear message and one voice, if you will. Obviously, there's a lot of different experiences across the council, but I think it's really helpful when you're going to legislators that we do really we're very succinct and very clear about our message. And I think Patrick and Kim did a great job collecting the information from the meetings that were had and really presenting it, I think, clearly and passionately. So I'm glad to see we're moving in that direction. I think Kathy Abercrombie would be proud of us.
Yes, indeed.
Right. Thank you.
Hi, Carol, is that you?
Hi, it is. I'm sorry. I was late joining, so I just wanted to ask a clarifying question. So was for the presentation, are we talking about making the change theoretically of the age for is this Medicaid or commercial insurance? I mean, what was, if I missed that, I apologize.
Kim, I'll defer to you if you want to
Yeah,
respond.
absolutely. It is commercial insurance that they're recommending that we're recommending the change, and it sounds like that is already being proposed. So it does not impact Medicaid. I'm not a Medicaid expert, but I do believe Medicaid already provides, Tara may know this answer, in terms of behavior health. Is that correct, Tara?
Well, like the information that Jennifer reports on, you know, for all of the autism services, that is 21 and under. And then there is, but people who are Medicaid eligible would have access then to DDS services where behavior support is provided if you meet that eligibility criteria, or if you meet eligibility criteria for the adult autism waiver, behavior support services would be provided there. It's not provided on ABA specifically is not provided on the state plan currently for 21 and up, but there is accessible services. Yes, there are wait lists and all of that, but there are services, and you would still have access to Medicaid. Recipients would still have access to all the other things like OTPT, all the other autism treatments that are listed in statute.
Thank you.
I hope I helped clarify that accurately. And Christine, you can jump in and correct me if I'm wrong.
You're doing good.
Hey, Melissa.
Good morning, everyone. I just also want to say thank you again to Kim and Patrick. That I thought that was excellent and put everything together and expressed it very succinctly and in a really informative way. So thank you. Another piece that I would like to say, as you know, as a provider working with individuals, is I've recently had the unfortunate experience of working with some individuals who have now lost both parents who don't have familial support local, and having some of these other services like, you know, ABA or, you know, services that could come into the home would be incredibly vital right now for them. And so I, you know, as a provider, am trying really hard to think out of the box and figure out what I can what I can, you know, what I can do to help individuals who are past the age of 21, 26, you know, who are living in the community now with very limited family support. And these services would be absolutely vital to allowing them to remain in the community and remain in the community successfully. So thank you.
That's the crisis that we have before us, and that's why the need is so great.
Absolutely.
Yep. All right, I don't see any other hands as it relates to the legislative update and priorities that we provided. I think I'm gonna go back to our agenda and we can pick up because we had moved the legislative priorities up to the top. Let's go back to the agenda where we do have public comment, and we can use the raise hand feature if you see that available, and then we can allow some time for that. Good morning, Sabrina. I see your hand.
Hi, good morning. I'm sorry, I'm in the car, so that's why my camera is not on. And this is actually my first time attending, so I'm happy to be here. But I am I'm the Executive Vice President and Chief Clinical Officer at Edelbrook Developmental and Behavioral Health Services. And I guess while all of this sounds absolutely fantastic and very needed, and I support it, I guess I'm concerned about the flip side of it, which is we don't have enough services and staff to provide services in the community now. I mean, we have backlogs of kids in services that have been on discharge delay for quite some time. So, and when I say we, I don't mean just myself, I mean across the state of Connecticut. And I guess I'm just curious, what are thoughts about being able to focus on increasing the services that are actually available? Paying for them is one thing, but if the services aren't there for them to utilize, that's my concern.
Are you talking about workforce issues or the overall coordination of services?
I mean, of course, workforce issues is across the board, across the country, but I'm talking about actual utilization to programs and services. We don't have enough programs. We've chopped programs so much in the state of Connecticut that there are not enough programs, whether you're under the age of 21 or over the age of 22, to provide services to the individuals in the system now. Let alone increasing it. Now, please, I 100% support this and think that they need to be able to have the ability to access those services. I'm just concerned that those services don't exist.
And that's a really good point.
And this is sorry, I'm not familiar entirely with Edelbrook.
Sure,
you
yeah.
serve both commercial and Medicaid?
So ironically enough, we would love to serve commercial, but commercial insurances do not pay for residential levels of care, such as ours. But yes, Edelbrook serves individuals between the ages of 12 and technically 21. However, the state departments didn't change their legislation with the Department of Education when they increased to 22. So we ask for special waivers for youth or young adults who remain in school until 22 so that they can resume residential treatment. So we provide residential treatment for individuals. We also have 15 homes in the community, both funded currently by DCF and DDS. It's dwindled, but right before the new year, we had 8 individuals in levels of care that didn't need to be in levels of care, and for an exorbitant amount of time, over a year, because there's nowhere for them to discharge to. So while I support all of this, I feel like it's twofold in the sense that they need services, they need funding for services, but the services also have to be there in the state. And I think those programs they're non-existent. They're inept at this point.
Thank you, Sabrina. I do have Lois, who's on our council with her hand up. Lois, do you have a comment or response?
Yes, I just have to echo what Sabrina is saying. It's a huge problem. Our waiver program is having difficulty. I don't know if anyone is on right now from the waiver program, and they could comment probably better than I. But I know that many people that are, eligible to receive services through the waiver now are not getting services because there are not enough providers to do the community mentoring piece, which is vital. It's a huge part of that program. And also, the job piece, the job coaching. Those are really, we are really in a crisis. And one of the things that is a priority for us to be looking at is how we are going to get, how we're going to turn this around, because she's absolutely right. Without getting trained providers in place, we can have all the places in the world, but people aren't going to be getting the services they need. There are many, I could go on and on about this, but I won't. There are many reasons this is the case, and I think, need to be addressing this. I think it needs to be one of our priorities as a council to try to figure out, what direction we're going to go in to get this done. Anyway, thank you.
Thank you, Lois. Sabrina, we do have another member of the council. Carrie is an educator and also a parent. Carrie, do you have any comments?
Yeah, I'm sorry. I apologize too. I'm also in the car. So, I just want to thank Sabrina for her insight, the insight that she's offered. And yes, I'm an educator. I work at a university training, helping professionals. I'm a psychologist myself.
Oh, Carrie, we're losing you.
Through multiple lenses, right? Everything that Sabrina has said, I think echoes in the thoughts of many of us who sit on the council, because these are the things that we have talked about. There are a dearth of programs, a dearth of providers, an abundance of need. And so how do we close or at least narrow the gap? That is kind of the charge of this council, is really to set the priorities and then start taking at least some steps to chip away at it, because it is such a massive, complex problem that there isn't, sort of a panacea to address all of that which presents in here. It is messy, it is entangled, it is complicated. And so I think we need to devise very strategic ways to begin to first set priorities, and B, start to chip away at that in a way that is, we can make some measurable gains, but it is going to take time. It's going to take a concerted effort. It's going to take a lot of people representing different organizations, agencies, government, education, etc. So we really need to identify the people, and I think some people sit on this council. Some people have, connections that reach out into other worlds that have the capacity or potential to make change. But we really need to find ways to, strategically kind of link arms and walk in the same direction to begin to address this. Because for as long as I've sat on this council, these are the things that we continue to struggle with, and, identifying an appropriate and feasible course of action to move forward. But it's good to hear from Sabrina, sitting in the position she does too, sort of saying the same thing, because it identifies another group of individuals to tap and sort of join this effort in getting our message across to those who can contribute to the change effort.
Excellent. Thank you, Carrie. Lynn, did you have a comment?
I did. Just to piggyback off Carrie's comments, we do have an active group working on workforce issues, as a provider, not personally, but the organizational provider of services. There are significant challenges in a competent pipeline of professionals and paraprofessionals to work with individuals with autism. So I see that as, a continuing primary issue here. Unfortunately, I think the reality is that has, in my world, gotten worse as workforce issues across the country have, been even more challenged, right? So I think workers have many opportunities, and employers have the burden of, trying to attract and train the best, and then to maintain them with competitive wages and great work conditions. So I think, you know, we are, this is compounded by what's happening all around us. I know Kathy has in the past talked about, you know, their workforce challenges. So not that we obviously need to focus on it, but I think that that is a barrier for us. And the group has talked about, you know, how do we first attract people before they even enter the workforce and engage them and get them excited about you know, the tremendous opportunity that there is to work with these individuals and how satisfying it can be and how great a need there is. And looking at best practice and how we can leverage some of these programs that do exist, because I love what Rep Exma said, which, you know, this is going to be iterative and incremental. And I think if we taking some steps forward are better than sort of stewing in the position that we currently exist in. And you know, I will say that honestly, that's how our program started here at the hospital, and with a huge needs assessment. And we dove in, you know, to the shallow end of the pool and just started doing something. And if you don't do that, you won't go forward, in my opinion. Just my thought.
That's really insightful. Thank you, Lynn. Carol next, and then Kim, you're up.
So I don't want to be preaching to the choir about staffing issues and needing a needs assessment, because that it is significant. The other thing I just wanted to put out there when we're talking about commercial insurance and raising the age, as a provider who bills commercial insurance for ABA and other services, as individuals start to approach the age of 20, commercial insurance starts to deny. So I think I just want to put that out there, because this is being recorded, that right now, if you have a child who's 20, 21, 22, commercial insurance is starting to deny and try to get you to justify why you need to consider it. So if we increase it to 26,
wow,
you know, calling you in front of panels and things like that to justify. Some insurance companies are more flexible than others. Medicaid is one that does not do that, but the commercial insurance, that's why I asked the commercial versus Medicaid. But many commercial insurances do start to tighten that noose as people start to get to that age. So I just wanted to put that out there, because that's maybe something that people are not aware of.
Good point. Thank you. Kim, I believe you had your hand up next.
Yeah, I just want to kind of reiterate that the one of the legislative asks around that needs assessment, all this conversation is exactly why we need that needs assessment, because I think we'll be able to better tease out those types of issues. And we did specifically talk about not only collecting the data on around individuals with autism on the autism spectrum, but also the providers and staffing around those providers, because we need to find out where those gaps are in being able to provide those services.
That's a great point, and one that I think Sabrina was specifically raising. So that's a great clarification to bring us back around to that, Kim. Lynn and Melissa, I don't know if you have your hands up from before or if you have additional comment. Go ahead, Melissa.
I want to piggyback on something that Carol said. I informed Anthem that I was going to speak about this. I've been having issues with Anthem as a provider. They cut my group rates so badly, by over 50%. I am trying to continue to take insurance. I know many folks out there are not taking insurance because of the way providers are often treated by commercial insurance. But when we're trying to meet the needs of individuals, I know there are IOPs for, young adults with autism, but after you get to the young adult area, there are not a lot of intensive outpatient programs that can meet the needs of individuals on the spectrum. So therefore, the weekly groups that I run really do provide pretty good support and help to keep individuals out of higher levels of care. And so I have gone up the chain as far as I can at Anthem to speak with them about the cut in rate to my group rate. And I've also brought this to the national level at the National Association of Social Workers. But that's just another piece, and piggybacking on Carol, that I wanted to bring up. I'm as a provider really trying to continue to take insurance, but I'm now losing over $500 a month as a provider. And I just want to, call attention to that too. Thanks.
Thank you, everyone. I don't see any other hands up. I do want to check and see if there's any other public comment. Oh, Marcia, did you have one more before we moved to the next
Yeah, I
item?
just wanted to piggyback on Melissa that she's absolutely right that many providers don't take insurance, and it's not because we, don't have hearts or because we don't want to be, providing service to communities. Just that we can't afford to, and the kind of loss that she's taken is admirable, but something that's not sustainable for most of us. And so I think that that's something that the different fees are only available for Husky. So pretty much people with commercial insurance are out of luck, I find, finding a provider who takes insurance.
Thank you for that insight as well, Marcia. Tara, okay, I wanted to see if there was any other public comment. I know we've been all responding to Sabrina's comment earlier. Anyone else? Will open it up for public comment if there's a member of the public that wants to speak. All right, otherwise I'm going to move to our agenda item. We have the approval of our November meeting minutes. This is kind of an administrative task here. Tara, those were sent around. Do I have a motion to approve the November minutes? Thank you, Lynn. Do I have a second? I can't see everybody.
Kim seconded.
Go ahead.
And yes, I apologize. They are on the website as always.
All right. No, that's fine. That's great. They're posted. All right. Thank you. November minutes are approved. Our next agenda item would be the Carillon update. And I believe we have Jennifer. I saw you.
There we go. Let me share my screen.
Thank
you.
I'm
not able to share my screen.
Yep, I'm going to need to give you permission. Hang on one second. Okay, you should be good to go.
Okay. All right. Can everybody see the presentation?
Yes.
Okay, thank you. So this is our December 2024 data update for Medicaid funded services for individuals with autism. We'll go through our regular slides, and then I do have an update to our provider map that I'd like to be able to show everybody as we have updated our interactive map on our website. So finally, really exciting. So I'll be able to show that to you as well. So here our rates continue in a steady upswing with the exception of our group treatment services, which remains at a low rate. That's mostly because of the reimbursement rate being much lower than other service that we're able to authorize and reimburse. The treatment plan and program book, the light blue line up here, is our highest utilized service, as that is available to providers every 90 days or as needed, as behaviors change or as individuals might be discharged from a higher level of care. That service is available to them to be able to reassess behaviors and make amendments to the treatment plan and program book. We then also, right below it is the behavior assessment, which is also available to providers based on behaviors and how they change. So those typically are our highest utilized services, and also sorry, the highest cost services as well. I know, Tara, I'm still coughing. Sorry. I'll get through this. Here's our current open authorizations for members. So again, a continued increase in service utilization, which is really exciting. We have 451 individuals currently accessing a diagnostic evaluation. We have almost 5,000, so we're at 4,900 individuals accessing direct services. So that's in their home, in their community, in center-based services, either delivered by the individual behavior technician or by the BCBA or overseen licensed clinician. And then our lowest one, the group treatment services, we have 81 individuals currently accessing that service. Here we look at the age of admission, and for those of you new to this, the age of admission is defined as the first authorization for ASD services. So that could be the diagnostic evaluation, that could be entering direct services. So it's just when they start to access our services. Our 3-year-olds continue to be the highest utilizers, which is really exciting as they transition from their birth to 3 services. We have 1,718 3-year-olds accessing services. And then the admissions by age continue to decrease. That doesn't mean that we don't have as many teenagers and young adults in services. It's just that they're not accessing it for the first time at those ages. A lot of times they're entering and then continuing services through their school age years. Here we break down our demographics for people utilizing the services. So unknown is the bucket of people who, when they fill out their Medicaid application, their DSS application, are not indicating what race or ethnicity they identify with. So that's in an unknown bucket. I know that our Carolina data team is looking to kind of dive into that a little bit more and see how we can get more information about that group of people specifically, just so that we can help diversify our provider network as well to be able to meet the needs of our member network. So that unknown bucket is the highest at 34%. We then have Hispanic group at 26.8%, white members at 20.6%, Black at 12.8%, and Asian at 2.3%. To the right, we look at how services and are authorized based on DCF region. So this is a pretty steady demographic that we look at as well. So region 3, that region that borders Rhode Island, while it has fewer members accessing services, we also have fewer individuals who are out there, as well as fewer providers. We only have 3 providers in that entire area of the state. We do have some providers who will provide services statewide, but it is typically hard to get out to that area. And we do have one provider in Westerly, Rhode Island, who does come and support members kind of in that Groton area, Stone-Easton area. So that is our lowest number for our regions. And then we have our highest, which is also a steady one, which is the DCF region 4, Hartford, Manchester region. We get a ton of referrals from CCMC emergency department. So we have a lot of providers in that area, as well as very saturated in members in that area of the state as well.
Jennifer, it's Jimna. I'm related to the demographic. Is there an opportunity? Well, let me ask. So these ethnicities, these are collected at the time of authorization or admission, or just
at their application, the Medicaid application.
So is there an opportunity, just in trying to collect as much, data as we can, that could be collected, like say through another, as services are being delivered, like have an extra form that just said.
So when we connect with families, when our care coordinators connect with families, part of our triage questions are what language they speak. We don't necessarily ask what ethnic or racial group they identify with, but we do ask what language they speak. So we collect that information on a very manual level. It's not in our database yet. We are working with our data team to really dive into that a little bit more, mostly so that we can inform our providers when they're hiring direct care staff. If we need more staff who speak Portuguese or Russian or whatever dialect of different languages that we have families coming to us, it helps us inform them as well. So we are looking to dive into that over the course of this year.
Excellent. Appreciate it. Thank you.
Sure. We also look on this page at our DCF involvement for our youth that we work with autism. So the largest group of our individuals, 96% are not DCF involved at all. We do have almost 4.5% of individuals who are CPS or DCF committed. Those children are typically living in a foster care setting, and we have been working closely with the DCF foster care providers and DCF workers to help provide some more training for those foster parents and clinicians specifically to support those individuals, because we know it's a small percentage, 4%, but they really do require a lot of support, and they are typically pretty complex kiddos who also come with some trauma and everything else that comes with being removed from your family. Our smallest, but definitely most complex group are the 0.02% of individuals who are accessing our autism services and are also involved in the Carillon Voluntary Program. So that's the old DCF voluntary services. And those individuals also have a psychiatric diagnosis in addition to autism. So by nature of that are highly complex. We typically have multiple times a week meetings about them and bringing in different providers and groups to be able to support their needs and prevent them from going into care. So while it's super exciting that our provider enrollment continues to grow, we do have 161 provider agencies in our provider network. We have a total of 1,182 total providers. So that includes the qualified providers who are able to do the diagnostic evaluation as well as oversee the direct service delivery. And then the number here on the left, the 1,044, those are the qualified healthcare providers who are able to oversee the direct service delivery. So we like to be able to break that down to be able to see the number of individuals who are able to actually oversee that direct service. That being said, we do not collect information on the number of behavior technicians who work at each agency, and we know that that's where we really need our provider growth is in those technicians who do the the meat and potatoes of the work and the really tough hours of after school and weekends and everything like that. So in relation to the staffing conversation that we were having earlier today, that's where we're really struggling is to be able to get behavior technicians working and staying with agencies. And I recognize too that there's a challenge when a member goes into an inpatient setting or has frequent emergency room visits. Those behavior technicians are fee for service. So typically providers need to switch them to another child in order to be able to pay them and to keep them on their staff, their service. So it is a huge challenge. I don't envy the job that our providers have to do in order to maintain and train staff. So it's not just a warm body that we're looking for. In Medicaid, we do have the higher requirement of having to have an associate's degree or a bachelor's degree, which is different from DDS that requires the high school diploma. Because, I think we've recognized at the beginning of our services that having that higher education and support helps to deliver, more quality services. So I know that is a huge challenge for our providers. To the right here, you see that the largest group of our providers are made up of the BCBA groups. That's no surprise. And then we also have random groups of providers that are made up of BCBAs, LCSWs, LPCs, LMFTs. And then our 4 clinics that are enrolled also have a number of providers, but they don't identify them out individually because it's a clinic setting. And then our peer specialists and care coordinator activities, this is the work that all of my staff do and, work directly with our members. It's the work that we're most proud of. So we have this top bar of individuals who are working to identify an appropriate provider, meaning that our care coordinators and peer specialists are reaching out to providers. We do this on a weekly basis, reaching out to providers to find out their availability, what their wait times are, what their staffing looks like right now. If they have staff that meet the unique needs of families, whether it's Spanish speaking or certain gender of behavior technician that they would like in their home, if the family is interested in center-based services versus in-home services. So we do all of that outreach, and that's the majority. That's our 77.5%, the tier 2 families that we support, that we're working to identify a provider. We then have 105 individuals who are on a provider's wait list, and our providers maintain their own wait list. So once they're on that wait list, we do still reach out to families to check in if there's any other needs that they have, but they really are just waiting with that provider to start services. Down here are all the activities that we engage in order to get a family ready to start looking for a provider. So we need a diagnostic evaluation, and as well as, you know, any other support documents. So we work to help the family gather those. We might be working to help transition an individual out of a higher level of care. I know we have our team lead who attends the hospital for special care rounds weekly, and we also attend their discharge planning meetings so that we can work with them in real time to get children ready to be received by a provider in their community. So the pie chart here, I had referenced the tier 2. That's our largest group of individuals accessing our supports. And like I had said, that's us reaching out to providers. Those are families who need some extra support in finding a provider. Our tier 1 families, the 14.5%, are families who are just calling in to say, where do I start? We typically will send them the provider list and they're like, yep, I got it. Just because we think they got it, sometimes they don't. So we do let our DCF partners and DDS case managers, as well as the hospital for special care, know that, you know, if there's a child who we thought they had it, and when they come into their contact, they don't have it, they could always call back into us and we can reopen and restart our supports. Our tier 3 and 4 families, while it's a smaller percentage of individuals, those are families that require at least weekly meetings. They're receiving a wraparound level of care where we're helping them to develop their own crisis plan and needs assessment for their own family to determine, you know, what they need as a family in order to maintain stability. So that's our data. Are there any questions on the data before I jump over to our map?
No, I don't have a question. I just wanted to make a quick comment. Last time that we discussed this, you had asked about the revision to, there were discussions around revising criteria for behavior technicians. And that I did follow up with Fatmata Williams, and she said that it's part of the state plan amendment. So the changes have been made, but we're still waiting approval. So I just wanted to note that, you know, there is something being done to address that gap.
Yeah, good point, Tara. And I do meet with them, with our state partners weekly. I know I have my meeting next week with them to really dive into that specifically, as well as some amendments that we're making to our level of care guidelines to support how providers actually use the services. So we are making some edits there as well. And I'm hoping maybe this quarter, I don't like to put timelines on things, but maybe this quarter, we can have some of those amendments that we could discuss in this meeting. That would be really exciting. Okay, so I did want to be able to share our map that we've been talking about forever in this meeting. Let me make sure it's on the shared screen. Here we go. Are you able to see the map? Okay, so the map has both the map setting that I'll demonstrate, but we also have a printable table version of all of the ASD providers. So for families who just need a printout, you can filter it based on where they live in the state, what service they're looking for. If it's a diagnostic evaluation versus the ongoing treatment, you can filter this list based on that, which is really helpful for our families. In the map version, you can also further filter down based on the language of staff as well as the clinician. So you can, you know, choose from all, and we gathered this information by calling all of our providers directly, asking them if they have clinicians who speak different languages, behavior technicians who speak different languages. So we have it broken down when you hover over, hang on, I have to get out of that. When you hover over it will say, you know, if they have bilingual staff, if it's center-based services, and then what region of the state they deliver services in, as well as their contact information. So we have that for all of our providers now. So whichever view is easier for families to look at, either the printable version. So I know a lot of our providers use that one to be able to print that out to just hand to families upon discharge of things. But families have really liked this interactive version. Any questions?
How frequently is it being updated, or would it just be in the
Provider
same
map
cadence?
is updated. So the actual map is updated monthly. The list is updated weekly. So the printable table version is updated more frequently. The map just takes a little bit more work to update. So they're doing that monthly.
Beautiful.
Yeah.
And Jen, where'd you say this was available? Sorry.
Yeah, no, it's on our ctbhp.com website. The link is in the slides that will be sent out so that you'll have the direct link and not have to navigate through the CTBHP website.
All right, that's awesome. Thank you.
You're welcome. And I think Jess also got that over to the social workers and everybody over at Hospital for Special Care too, Lynn.
Thank you.
Yeah. All right. Thank you.
Thank you, Jennifer. On the agenda, I don't have any additional agenda items.
DSS for autism dates.
Sorry about that. That would be important.
Hi, good morning. This is Christine Weston, the Director of Home and Community-Based Services over at DSS. A few things. One, I would like to be moved off following Carolyn on the agenda because it's just an amazing presentation. And I think I'm going to make a New Year's resolution to this group that DSS is going to start modeling that level of presentation, and we will be able to start kind of reconciling our data a little bit better for you and giving it less informally and more formally in that kind of level of presentation. That was phenomenal. And I can't wait to actually like dig in and look at it. So thank you to the team at Carolyn.
We have about 20 data people who work on that, so I can't take credit for it. I'm just
it was incredible. And I said to our new manager, who I'm going to introduce, I'm like, we're going to figure out how to make it look a little bit closer to that. But yeah, I don't think it's going to be. I may need to tap some help on that, or get your clean PowerPoint so I could just kind of plug and play some of our stuff. But before I kind of get into any of our updates, I did want to introduce the autism waiver now has a manager directly overseeing the services. So Mike Olson is still as our case management supervisor, which you know, and is on some of your subcommittees. And we still have a solid team of 9 case managers doing the great work of the autism waiver. But we have welcomed Susan Stang onto the into the community options managerial crew, and it will be overseeing the autism waiver. So Susan, would you like to just introduce yourself and say a few words?
Hi, everyone. Nice to meet everyone. I'm looking forward to managing the program at DSS and getting to know everybody and becoming an amazing data visualization expert. So yeah, I'm just learning a lot about the program, and again, looking forward to working with all of you. Thanks.
So I'm not going to ask her to kind of be on the spot quite yet today. She's been here, I think, 2 full weeks, maybe 3. So as we get her integrated into this great work, she'll start taking over, kind of presenting moving forward. And Tara, I do owe you some of our formal numbers. We'll get that before you, like we'll ask you to do it as an addendum to this notes. I don't have something formal to present right now. We're in the process of also finalizing our annual report, which, you know, I think, unfortunately, we had asked legislation to make it fiscal year data. It's still calendar year data, and it shifted responsibilities from OPM over to DSS this year. So we're slightly delayed in getting our annual autism report out, but that will be coming mid-February, I promise. So that will have some additional information for you guys all to look over. And if anyone wants us to walk through that report at the next meeting, we're happy to do so. So all of that is to come. As I did state, you know, so with the autism waiver, we are currently down 2 positions and have as of July 24, we're given a tremendous amount of spots and waiver slots to onboard more people. But being down case managers, and as we also heard from Sabrina and others on the call, the provider shortages and just the overwhelming barriers, we are not quite yet at our numbers where we wanted to be with onboarding. So we have around 350 active cases. We have permission for 440 positions to kind of fill, which we're looking at over the whole year. So by this July, we hope to have 440 active participants and then start our next 200 active, which will also require 5 additional case managers. So absent case managers and then providers, so if we're talking about expanding access, we need to have providers that can absorb those individuals. So those are things that we are very astutely aware of and really trying to figure out mitigations and ways to support 200 more individuals being able to access autism waiver services come, the start of July. So things that we need to continue to kind of plan and think about. 2 of the positions should be refilled soon. So anyone that's not familiar with state government, there's multiple layers of approval processes. We've gotten through one gate. It's at the next gate. So hopefully those positions will post, I'm hoping in the next few weeks, which means we can then start, modifying our caseloads, backfilling some of them and then onboarding the new people. So I'm very excited for that. And then I will immediately begin advocating for the 5 positions to support the 200 new waiver participants. I have been hearing your concerns around the needs assessment. Tara has reached out in the past about how DSS can support this. And I think we do. I would like to say publicly, from DSS's perspective, we need to understand where the gaps are and what we're actually planning for in the future, right? Because the cohort right now is just going to age in place with us. And part of HCBS is doing that long-term visioning and what's going to be needed down the road as all of these individuals age and their caregivers age. So I very much support everything that's been said around this needs assessment and really what that looks like for HCBS demand in the future. These will eventually be potentially home care program for elder participants at some point, right? There is this continuum of need and growth for care in the community, and we need to start heading it off now. We can't try to solve it later. It's a problem now. So I think I want to continue those conversations. There could be some ideas on how we could potentially support the assessment and figure out how to do that. Because ultimately it will help us drive where the care needs are going to be over the next few decades for these individuals. So good luck with your legislative session this year. I know it's going to be an intense one. And right now, all of our, the numbers for the waivers really haven't moved that much. So we'll formally submit the numbers to Tara and you guys can see that we still have around 2,100 people waiting for services. It is still years out. We have the 440 slots that we are ramping up and trying to get people on services as fast as we can. When those new case managers come on board, I hope we can quickly orient them to the work and the services and get them kind of at full capacity as fast as possible. So is there any questions for DSS? That was our quick report out.
Just want to,
Yep.
It was to meet you virtually today and look forward to having you as part of the team.
Yes, welcome.
Thank you so much. Appreciate it. I'm looking forward to it too.
Stay tuned to our very fancy presentation next week. It will be great.
Big shoes to fill. Okay. Tara, I'm looking at the next item on the agenda. Do we have any new business or do we have anything else that we need to wrap up here?
Agency updates, but I'll just, if we want to just ask, I know Krista couldn't join us today. She said she didn't have any, but for any other state agencies that are on, is there any updates from anyone? Yes, Anne.
Hi. I would like to let you guys know that here at the Department of Public Health under the Maternal and Child Health Bureau, we do a needs assessment every 5 years, and we're in the process of doing it right now. Certainly it's a broad assessment of maternal, infant, perinatal, child, adolescent, and children with special health care needs. And we are right now just finalizing some contracts with a third-party provider who will assist us with the needs assessment process. Part of that is we've already put together some of the federally available data that's on the topics of reference that we look at based on the categories that I mentioned, or we call them domains. And we will be going out to the community with this third-party contractor to get feedback into the areas of need. So we certainly will keep everyone posted as to when these community meetings are available. What we do is once we finish this process, we do end up coming up with a 5-year action plan based upon the needs that are out there. Sometimes these topics include a wide variety of efforts because we're trying to put something in place that's going to support 5 years. So we'll be happy to continue to update you as to where we are in that progress and make sure that we are thinking about the population and the discussions that happened in this group. I don't know how quickly the needs assessment might be finished if it is approved and finished here. But even moving forward, it is something that we would be able to look at and integrate. So thanks.
Excellent. Thank you. Hi, Lynn. I see your hand up.
So Anne, thanks for that. I think you might remember years ago we worked together on a needs assessment. So I'm happy to have our team be a part of that because some folks on the call would know that as hospitals, we're required to do community needs assessment. And because of the specialization of our hospital, it often is very challenging to come up with meaningful areas to focus on. But given our focus on autism and Anne and I have worked together in the past on this, I'm happy to be a part of that. I think that would maybe help both of us, particularly now with the numbers that we have. So that was one comment. But the other seems very small, but just so that we can plan. And we've had great autism days at the Capitol. I might be calling it the wrong thing in the past. And I think with this very robust agenda that we have, it's great to get ahead of that. And I'm not sure who's planning it this year. I don't need an answer now, but if anybody can make sure that that information is disseminated, happy to support that again this year. So
I will watch for that, Lynn, and let you know. It's usually in April, right?
Yeah, it is. Yeah, it's tends to be rather late in April, I think, lately. But anyway, whenever it comes out, I think if it can get disseminated, I think for whatever reason, last year we learned about it the last minute. We did certainly attend and participate, but it'd be great to have a strong showing because we have been very fortunate to have a lot of interest from legislature as we are and other administrative departments when we're there. So this is a great opportunity for us.
And I'm happy to work with you, Lynn. Thank you so much for mentioning that. We'll definitely include you in actions and activities going forward. So thanks.
Thank you, Anne.
Any other agency updates? Okay.
I'll just do a quick one. So I know we had discussed having a formal meeting around watching, different bills that are being proposed. And I am personally following that and will be happy to send out just links to different bills that are being proposed. I'm also happy to help, walk people through how to follow bills, through the CGA website. If anybody is interested in that information, I can, be happy to show you how to track bills. There is one that's already proposed for additional waiver slots. So that is, I don't know, Christine, if you saw that already, but we'll note.
And I'm like, as long as there's people and providers somehow attached to it, we're gonna. I mean,
It's just funding for additional worker slots. Is all it said. So, you know, that is one as an example. Again, you know, the information Rep. Exum was referring to, you know, that's all to be developed. That's not anything that's currently out in a formalized way right now. So it's a TCB recommendation. They have their meeting later today. So we'll, you know, that's definitely another one we'll be watching to see if there can be some insurance reform. But for anything else, if, like I said, please reach out. I'm happy to assist anyone in how to follow that. Otherwise, I'll try to send out an email. Things can change pretty quickly, but definitely will look to alert the council if there is any kind of formalized public meeting. If the group wants to come together and have any additional meetings around proposed legislation, please reach out to me directly, and I'd be happy to help, you know, on the administrative side for that.
Thank you, Tara.
This is Anne. May I also add, I can forward Jenna this information, but part of our Maternal and Child Health Coalition work on January 28th, Allison Johnson, a public policy consultant, is offering a presentation from 9:30 to 11, basically a legislative workshop. Certainly the focus of this workshop is about understanding the stages of the legislative process, including how bills are raised, submitting testimony, identifying key committees. This is for maternal and child health, but I think portions of this could be applied to anything. Identify points of public influence and be able to track legislation online and understand opportunities. This had been offered before in the past to Allison. Allison offered it before to this group. This is a pretty large group of maternal and child health advocates who come together, who provide kind of a lot of oversight and support to a number of areas. So if you'd like, Gemini, I can forward this to you. And if you'd like to, you know, share it with the membership, if you guys feel it's appropriate, it might be interesting. Mary Jane Carey is the person who helps organize this.
And thank you. And do you know if it will be recorded, or is that really up to her advocacy group to run it?
I do not know that.
Okay. Yeah, that for the information, that'll be fantastic.
I could find out if you'd like. It wouldn't be a problem.
Great. Thank you. Hi, Lois. I see your hand up.
Yes, I was wondering, do we now have an active education committee that's working on training, looking at, you know, what we might be doing around training? I thought there was, Tara, do we?
Yes, we have Lynn is chairing that subcommittee. We are currently meeting the 4th Wednesday of every month. All meetings for this calendar year are posted on the ASDAC website. And I believe the next one is in
I think we only missed December, but we've been meeting regularly every month and have actually had very good participation, thanks to the folks who were able to join us on that.
That's great.
So it is week, the 22nd at 3 o'clock.
Yeah, could I just ask Lynn a question about that?
Of course.
Lynn, are you looking at how we can get possible providers trained? Are you, you know, what specifically is the committee looking at?
So, you know, we started by really looking at kind of throwing it all on the table and tried to identify where the gaps are. We actually had Jen come to the meeting and, you know, talk with us. Jen Crone come to the meeting and talk with us about what she's seeing. And I think this map and the information that she provided helps to kind of focus our energies into where the gaps are. And I mean, there's been lots of great participation. We've tried to identify, you know, what programs exist, what are best practices in programs, how we can try to replicate some of those programs, you know, and really just try to focus our energy. I think we've probably met about 4 times or so.
Mm-hmm. Yeah, I guess I was thinking more, you know, I'm looking, for instance, at the waiver and the fact that the waiver program is having, you know, their providers out there doing the work for that program are very sparse, is my understanding. And I think we're either in a crisis situation there or heading into one. So if we're looking at bringing on more people, we definitely need to be, you know, have the providers to do the work. So yeah, anyway, I'm just sort of putting that out there. I know that's easy for me to do. I'm not participating in the committee, but you know, I personally think that we need to be focusing some on that as well. Waiver folks could probably tell us better, but I think we're sort of. Is anybody still on from the waiver? Christine?
Yeah, so I had indicated, Lois, in my report out, we're very concerned about our provider capacity, right? So as you guys know, we lost a major provider in 2024. Those individuals then had to be absorbed by the other providers that were already kind of stretched. We have statewide issues. We have a couple of issues around the provider pool. We've been asking Mike and the case managers to start collecting that data. So what we need in Medicaid is kind of like the hard data, right? The anecdotal stories are great, but we also need to see where are the true access issue points? Where are the issues where care plans are being either changed or altered because services are not available? So that's the data collection we're working on. We really need to be able to articulate the need, you know, and to make any sort of justification for rate increases, workforce development, anything that we would want to do. I need the data behind it. We certainly know anecdotally and from the stories and from what the case managers lived experience with these families, we have an access issue. Trying to pinpoint the mitigation strategy and how we can approach it requires a little bit more drilling down. Also work I'm hoping to start doing more with Susan, get some information from the work that OPM has done, maybe get some of the background data from that report and see what we can do. We know we have a problem, Lois. I don't have a solution. I don't.
Yeah, I mean, there's so many factors, I think. You know, first of all, this is a unique program, and the number of hours that most of our folks need are not typical. And I think that's part of the problem, too. Maybe I'm right on that. You know, if you have somebody who only needs a few hours a week, but those few hours are crucial, you know, to their success, you know, in functioning independently, it's really, really important. So, but I understand that providers have a difficulty, you know, in finding people that are only, you know, that they can only give a few hours to. So it's a very complex problem, I think. But I think that, you know, if we can be helpful as an advisory council, you know, I think we should, because I think this is a huge problem and we need to get on top of it. Thanks.
Sure. Happy to put that on our agenda for our next meeting to just have some continued dialogue about it. It's not a new item. I think it's helpful information because, again, we're going to have to prioritize. We're not going to, obviously, if it was easy to fix, it would be done, right? So we'll put it on the agenda, Lois.
Thank you.
Okay. Kara, I don't see any other hands up. Is there anything else we need to cover? We're at about 20F.
Nope, I think we're good. We can give some people time back in their day.
Excellent. Wow. This was a really great meeting. I hope all of you are feeling energized, looking forward to getting our priorities aligned with other councils and legislators. I'm really appreciative of all your hard work. Thank you all. You make my job easy as your chairperson when I get all of your feedback and your participation. So thank you, and we will see you next time.
Okay, Happy New Year, everyone.
Thank you.
Happy New Year.
Happy New Year.
Thank you. Bye-bye.